Last but not least, tension band fixation. Dr. Meckler asked that I speak about the tension band and is it going away, and are plates really the answer? I don't have any conflicts. I do want to give credit to the AO Foundation. I stole some of their technique slides for the discussion. So, historically, most of our fixation, we've come a long way since 1843. And for the last 60 years, we have used tension band techniques. I think we've gotten better at them. We've had different modifications, but the philosophy of the tension band, I think, is still an integral part of our fixation techniques and what we have to offer our patients. The tension band can be used in other places than the patella. We use it frequently for the olecranon. Some of the transverse fractures in the geriatric olecranon are very nicely treated with the tension band techniques. I like to use them for small little fractures at the tip of the malleolus, both medial and lateral. It's a very elegant way, and it's a way that I can teach the fellows how to use the tension band because nobody's really super familiar with it anymore. The osteology of the patella is interesting in that it has a concave, large articular surface and an extra articular surface that's very difficult to contour the plates. So it's important if you're going to use the plate fixation to spend the time. There's a lot of pre-contoured plate fixation now that's available that you don't have to spend as much time. But the patella is a tough little bone to reduce. It's tough to get the articular surface just right. And I don't think the patella gets some of the respect that it should. Don't be caught with the bipartite patella trying to fix something that shouldn't be fixed. Mechanism of injury for the patella, the indirect mechanism usually leaves us that transverse pattern. The direct impact, the so-called dashboard injuries, usually result in a comminuted fracture pattern. Many of those are open. The physical exam is pretty straightforward. I wouldn't do this on an awake patient, but you can actually palpate the little defect. And the radiographs are pretty easy to interpret, even some of the comminution. I'd say that we're using more CT scans now than we used to. We use CT scans to look at other articular injuries, and for some reason we haven't been as aggressive on the patella. But I think that if you have a younger patient with a comminuted patella, I think the articular reduction is equally as important, and so I think the CT scan will help you. MRI for non-operative fracture management, especially in some of the patients who may have had a dislocation that have an MPFL injury. The sports guys are fixing these now, and a lot of times they'll do an arthroscopy and clean up the articular injury on the patella as well. So what is this whole concept about tension band? Well, basically, if you apply a bending force to a rod, a tube, or a femur, for example, and eccentrically loaded, on one side you're going to have a tension distraction force. On the other side, you're going to have a compression force. And the idea with the tension band is that you're going to neutralize the tension side and create compression at the interface. So what happens, obviously, when you apply an eccentric load to a beam? Well, you're going to have a fracture exactly like what we're talking about, these transverse injuries of the patella. One side is loaded in tension, the other side is loaded in compression, and we're now trying to neutralize the tension side. Same thing happens in the femur. Laterally, we have the tension. On the medial side, we have the compression, and that's why we put the plates on the lateral side to neutralize the tension side. Now, if you don't have support on the medial side, if you have comminution, you're going to have a fixation failure that's going to require a revision. So the technique, all of us are pretty familiar with it. The incisions are pretty straightforward, just anterior incisions, and once you find the interface of the fracture, you just work on the reductions. I usually make a small arthrotomy medially where you can put your finger and palpate the articular surface on the inside. You can actually pull the patella up and visualize that. You can work on your articular reduction. So I'm not opposed at all to doing the medial arthrotomy so you can actually see. There's all kinds of different clamps. Here on the left is a Weber reduction clamp, and on the top is the patella reduction clamp. And then you simply start placing your K-wires. There's all kinds of different guides to place the wires in a parallel fashion. And then I use this 14-gauge angiocath to pass the 18-gauge wire. And you try to make the reduction and the fixation elegant. You want to try to get the wires close to the bone to try to prevent impingement. There's all types of different wiring techniques, but I spent a little time and found some older literature that suggested that D on the right side there is the best wiring technique, that it creates the most compression at the interface. And so by using parallel wires and a pattern of 8 fixation and tightening the wires from the top, that gives you the most compression at the interface. There are some percutaneous techniques that have been talked about. I tried this. I think it's kind of technology over reason. You do a lot of subcutaneous stripping. I think that that there are some new percutaneous screw implants that are currently being looked at in the lab, and I think the tension band percutaneous techniques will probably fade away. So in general, just like everything else, try to make your fixation elegant. Try to keep it close and tight to the patella. I think it decreases the amount of hardware pain. So what about the plates? The plates are currently all the rage. All the companies have them. There's a whole bunch of different designs. We've used locking plates on other parts of the body for a long time, and now for the patella we have locking angled screws with different different thread patterns. We have variable plate designs. I don't have a preference of one over the other. I do like these titanium mesh lock plates. You can use them as augmentation for fixation that you're not satisfied with, or you can use them as a primary fixation technique. There's quite a bit of data over the last 6 years or so on the advantage of using the plates. I wish Joe Borelli was here. We had a discussion 5 or 6 years ago on this panel, and I remember he beat up on me quite a bit about using the plates. And I told him, I said, I think someday we're going to have this discussion later on, and I'm going to end up being right. So he finally admitted to me that I was absolutely right, that the plates do play a role. But he told me he still uses, just to spite me, he still uses the tension band technique. Functional outcomes, here's a study in 21, excellent outcomes with plate fixation. Another one from the Journal of Trauma. So there's abundant literature suggesting that plate fixation, contoured plate fixation works just fine. The plates, I think, work well for malunions. Here's an OIF. This is a nice, elegant placed screw and tension band technique, but unfortunately there was no reduction. I think that you can take these back to the operating room and remove the fixation and use the plates in a dynamic compression fashion, and I think they're very effective for revisional surgery. Severe comminution, they work fine. Use the same techniques, and plate fixation seems to work well there. Here's a technique that I really like, I think, for patella fractures and total knee replacements. If the patellar component is stable, I think it's a nice technique to use. Just use a Weber reduction clamp and reduce the fracture and place the plate. And a lot of times you can actually run the screws into the patellar component, and you can look to be sure that they don't penetrate and impinge on the femoral side. So that's a really good technique for the arthroplasty team that has a failed patella. So finally, I think that I think the tension band technique is still here. I think we still should be using it. It's best for simple transverse fractures. It's inexpensive. It's technically easy. I just encourage you to do a good job, make your fixation look good, because it will decrease the amount of hardware pain. And I think for the future, I think we're looking at smaller incisions, advancing plate technology, and percutaneous screw techniques for patellar fractures, and obviously our colleagues in the physical therapy department. Thank you very much.